Hello, everyone. Good evening, and welcome to our new interns. Practicum students, before we even dive deep into our clinical work, I want to make sure that you guys completely understand how we do case conceptualization. You might have studied this in your coursework, or you might not have a clear understanding, but this is super important to keep in mind. So the presentation is about how do we create really good case conceptualization so that the work that we do becomes easy. The purpose is when you're working with the client, you might find yourself becoming overwhelmed all over the place. But if you have a clear roadmap, the work will become easy. So who is this presentation for? It is for all our counseling students, interns, practicum students, supervisees, if you're in psychology field or social work field, if you just want to understand the concept of case conceptualization, then this presentation can be helpful. So why is this important? Because case conceptualization, I think, is one of the baselines. It's a guide to understanding, organizing, and applying client information in a meaningful way. So again, this is for all our interns and counseling students. Case conceptualization is important so that we can understand, organize, and apply client information in a meaningful way so that even when you're doing your notes, you understand what is happening, what is the issue, how do you visualize, how do you zoom out, how do you become objective, and how do you proceed in your clinical work. About me, I'm Aditi Jazra. I'm a clinical director for Wellness North Counseling, and I also oversee the practicum program. And I'm also co-founder of a non-profit organization called New Wellness North Foundation, through which we support folks who cannot afford counseling, who are looking for resources. So we do a lot of pro bono and free work as well. And we support students through that too. So feel free to review this information and share it if you find it useful with your fellow students, with folks who might be struggling with understanding the concept of case conceptualization. So when a client comes to see you, you want to make sure that you have a clear understanding. And let's see. So what I want you to understand after this presentation is that what is case conceptualization? That concept needs to be clear in our minds, understanding its purpose in counseling, identifying the key components. So when I say, have you done case conceptualization, or when we are having a conversation, supervision, um, a workshop, I want to make sure that you understand the case very clearly. You can apply different models, frameworks. We will go with the 5P model, one of my favorites. And then you can practice developing a case formulation. So learning objective is clear understanding as you step into your role as practicum intern with Wellness North Counseling, as you begin your practicum journey, or maybe you are at the end of your journey. I want to make sure that as you graduate, some of the key concepts are clear, the modalities, the skills we would want a good counselor to have, as well as clinical skills. How do we conceptualize a case? What modality are we using, and how are we doing our clinical work? So, what is case conceptualization? It's a structured way of understanding a client's concerns. I'm big on setting goals while we're working with clients. Sometimes we might not set goals, or client might just want to come and talk to us. It can very well be just talk therapy, but structured approach makes it easy on us as well. So that's why I love modalities like CBT, DBT, but personally, I do go with bottom-up approaches, do a lot of trauma work, and trauma is held in the body. So bottom-up approach is definitely my favorite. EMDR, again, can be very structured. That's why I go with DBT, structured approaches, basically. So what is case conceptualization? It's a structured way of understanding your client's concerns. It explains why the client has problem and what maintains them. It also informs our treatment planning and interventions, and it acts as a map for therapy. So the therapeutic work that you will do, there has to be some kind of foundation, right? So this case conceptualization is basically your map. It's a structured way of understanding what are the presenting concerns, perpetuating factors, precipitating factors, um, and other contextual information. So it helps us in understanding why the client has problem and what maintains them. And then we can, once the concept is clear, once you know what's going on, then you can create interventions, you can do treatment planning. But first 3, 4, 5 sessions are always about building rapport, right? Using that non-judgmental lens. Um, really plugging into clients' world, trying to understand who they are, where they're coming from, and then as you're having those conversations, you're also thinking in broader terms. You're thinking objectively rather subjectively in terms of, okay, what is happening with this particular person? And you are using person-centered approach. We want to use Rogerian methods. Why is it important? Why am I saying, folks, let's make sure we understand how to do proper case conceptualizations? Because it guides counselors' focus. You don't want to be all over the map. You might have, 5 people on your caseload, and all 5 can be same age group, same kind of, presenting concern, but the context can vary, right? So it helps you to focus. It guides counselors' focus. It prevents overwhelm. It prevents random, unguided sessions. So, as much as we are about collaboration, going with the flow, you do want to have some kind of a roadmap. And you want to have goals. You want to ask your clients, what's the goal of therapy? How would they know the work that we are doing is working for them? Sometimes they may have goals, sometimes they may not. But with case conceptualization, even when you're coming to, say, supervision or in our group sessions, you're not just presenting information. You have a little bit more clarity in terms of what I'm presenting, where am I struggling, how do I move forward, how do I become a better clinician. So it helps you in understanding clients' concerns and more clarity. It also helps in anticipating challenges because the map is clear. All the pieces of the puzzle have been put together. And there might be more pieces that keep coming up, more information, more data. And that's why we continue to evolve, refine, refresh the information we have. So it helps anticipate challenges and relapse risks. It also provides the rationale for choosing the techniques that we want to use. Why do you choose particular modality? Why CBT? Why narrative therapy? Why EMDR? Why DBT? So the rationale for choosing a particular modality, particular technique, particular intervention could have been decided based on clear roadmap. Roadmap, your case conceptualization. Some of the core components. So, what is case conceptualization? So, what we are looking at is mainly what are clients' main issues, what are presenting concerns, what brings them to therapy, what is going on for them. So, you gather background information, but let's make sure that the work is very therapeutic in the sense that when clients come in, they should not feel like they are being interviewed. Oops. Uh, okay, my bad. Sorry. So what I'm saying is background information. So as you're gathering this information, it has to come to the front in a very natural way. We don't want them to feel that they are being interviewed. Sometimes you can send them questionnaires so that they can fill information, or this could be first or second session. But it can be a very fluid process too, depending on what kind of counselor you see yourself to be. Folks who are coming from, say, structured systems. They have a certain way of doing things. I've worked with nonprofits in the past where we had questionnaires we would do in our first session, or there is full on intake team. But in our private practice, in our nonprofit work, it's a very fluid process. But still, we work within system. We work with ethics. We work with, the core foundational pieces of our clinical work. And one of them is our case conceptualization. So, what are the clients' presenting concerns? You are gathering the background information, history, when the issue started, what was growing up like for them, a little bit more about their family structure, what is their routine like, what culture do they belong to. Some of these things might be very evident. The client is talking fast, they are seemingly anxious. Maybe that's how they are in their everyday life, or maybe that's because they're nervous about their session with you. Then we are looking at predisposing factors, so vulnerabilities. So here you are considering biological factors, psychological, and social factors. Did they not have any support growing up? Um, is there history of mental illness, mental disorders in the family? Were they born with certain traits, certain certain conditions? So what are predisposing factors? What are their vulnerabilities? Here you're looking at biological, psychological, and social factors. And then we are looking at precipitating factors. What triggered the issue, right? How come they did not seek support, help in the past? Some of them might have had a lot of therapy in the past, and now they just want to change counselor, or this was not the issue in the past, but sudden shift, change in the situation, whether it's work situation, professional, academic, personal, something happened that triggered the issue, whether it's depression, anxiety, this profound sense of sadness, hopelessness. What happened? So precipitating factors, what triggered the issue, per perpetuating factors, what maintains it. So that again, how long the issue has been going on. So what maintains the issue? What are their protective factors? What are their strengths and supports? And I really like this protective factor piece because we sometimes forget about human resilience. A lot of folks before us have struggled, like our forefathers had struggles, challenges, and they overcame um, those struggles, right? So sometimes the conversation I would have with the clients is, tell me more about your ancestry. Everyone in the family was an educator. Everyone in the family was a fisherman, right? So it's like it gives you a little bit more. So everyone in the family, forefathers, ancestors, everyone was in, say, fishing industry, or they lived in a certain place where they were surrounded by water. So their protective factor is actually swimming because they grew up around water, right? So really zooming out, considering their strengths, their supports. Um, did everyone in the family study? Everyone holds a master's level education. So that is a strength. Education is a strength. Or everyone talks about issues very openly. Mother had depression. Mother was always talking about it. Mother was taking medication for depression, right? So it gives you broader perspective in terms of what's happening. Predisposing factors, precipitating factors, perpetuating factors, protective factors, and then you are summarizing, taking like, that hypothesis. Seems like they have anxiety, they have depression, they have OCD, or they're struggling with grief, they just lost someone. So it just helps you create a formula, a plan. So 5P model, one of the major ways in which we do case conceptualization, presenting problem, predisposing factors, precipitating factors, perpetuating factors, protective factors, one of my favorite slides. You can save it, you can refer to it. Even as you're doing intake, you can have, okay, let me look at key components I want to investigate with the client. And again, you're not doing it in an interview manner because you are going to be set apart from your peers, colleagues. You want to be a better clinician. So that's a conversation, right? It's bringing your warmth out, it's bringing your empathy, your non-judgment out, versus like medical model where, someone comes in, takes the information, what's wrong, something like that. Since when you've had fever, what medication you were taking, right? So don't make it clinical, make it more person-centered, more compassionate. But this is information you're trying to gather. Don't forget the protective factors. How have they survived past challenges, past traumas? Or maybe they didn't survive. Maybe they shoved it all under the rug or suppressed, and that's why they're coming to see us. So theoretical lens, you can choose whatever theory you want to pursue. A baseline is generally cognitive behavior model, CBT, where the focus is on thoughts, behaviors, the cycles that clients get stuck in. You can go with psychodynamic procedures, unconscious processes, early relationships, Oedipus complex, all the work that Freud did. Um, So if you want to use that, it's not very popular, but you can definitely conceptualize based on psychodynamic model. Then very popular humanistic, existential, more talk therapy. We talk about meaning of life, self-concept, values, when did the schemas form. You can use systemic lens, family, culture, social systems that influence decline. I myself use sometimes structured approaches like CBT, DBT, challenging some of their distorted cognitions, a lot of somatic work, body-based approaches, um, and also EMDR and EFT, emotion-focused therapy. You can go with solution-focused lens as well. If they have limited funds, they can see you only for a certain number of sessions. Okay, let's look at a case example. So there is a 22-year-old student with anxiety about exams. So if you were to conceptualize it, you're looking at, okay, what are predisposing factors? There is family pressure, um, maybe the clientization. So family is very much about you have to ace the test, you have to get admitted in this program. And they always want to achieve 10 out of 10 in order to please family members. But recently, precipitating factor could be recent academic failure. Now they're having panic attacks. And perpetuating factors, what's maintaining the problem? They are avoiding studying. Negative self-talk, oh my God, I'm going to fail, I'm good for nothing. But the protective factor is that there is motivation for therapy to figure out what's going on for them, to do better. They have some self-reflection, some insight. They overthink, they're telling you this information, and they have supportive peer group. There's no competition within friends. Everyone is supporting each other. They study together. So these could be their protective factors. So you're formulating the case thinking, okay, anxiety that the client is facing about exams is maintained by avoidance and critical self-talk. Treatment to focus on CBT techniques, self-compassion work, maybe mindfulness, maybe there is lack of self-care, introducing that, perhaps not taking this academic failure close to the heart. Maybe they were sick, they could not study, maybe exam was really tough, everyone in the class failed. So there could be a lot of factors, right? So challenging some of that critical self-talk. Anxiety is maintained by avoidance. They're not studying before the exam because they're so stressed. They're chatting to all their friends. Everyone is saying we are studying, but they're unable to study. So there could be different ways to look at the problem, but this could be one way to formulate the case that anxiety is maintained by avoidance and critical self-talk. And we are going to use CBT techniques, challenging negative thought processes, cognitions, distorted cognitions. I should study, or um, I would, I would fail. So would, should, could, we avoid that, right? So, and self-compassion work, they're being very critical. There is, yeah, but you can also look at that from IFS model, like internal family systems. Always this rebel shows up. Rebel says, I don't need to study. And then there is this critical part that comes up that says you're good for nothing, right? So how do we invite the cheerleader? How would they talk to a friend who has failed the exam? So those can be interventions based on formulation that you've done. So what I would love for you all to focus on is gather information. It can be thorough. It can be based on what information they're giving you, what they want to talk about. So this is the baseline, first session, perhaps intake, interview. You can do assessments. You want to really dig deep. You can do GAD-7. You can do PTSD scale. Few of them available to us. We never give a diagnosis. We are only doing diagnostic impression. You are organizing information in 5P model or whatever framework you choose in order to create a rough roadmap. You're identifying patterns. People pleasing is there. Negative self-talk is there. They're being too hard on themselves. Lack of boundaries. So identify the pattern cycles. How is all the information linked together? Dad was always saying you've got to get 10 out of 10, or dad was absent. Mom was always on their case and they want to please the dad, and dad will only talk to them when they get good grades, right? So noticing that link. You're developing a working hypothesis. How are you going to approach the case? You connect formulation to treatment plan. You review and revise as therapy progresses, and always use SOAP notes, subjective, what the client is saying, objective, what are you noticing, what's your assessment, what's the plan. We will use EFT techniques. We will target their sense of failure. We will target loneliness, frustration, right? So what is the plan? How are we going to achieve what we want to achieve? And this also helps so that, if your notes are to be subpoenaed, they're very clean, crystal clear, less doubt in them, and you're not spending whole day doing notes, right? Like we keep them short and simple. So KISS, keep it short and simple so that if they ever get subpoenaed from insurance point of view, from legality point of view, you're keeping things clear and simple and transparent. You're protecting yourself, your supervisor's license as well. Common mistakes that we've seen folks make: they use only clients presenting complaint, which is very now oriented, which is okay. You do want to have some context. So knowing some of the additional factors is giving you that context. Or we are ignoring strength and protective factors. We are only trying to resolve the issue, not considering that they're resilient. They have survived without us their entire life. Even if they don't choose to do therapy, they will be fine. And that's why it's always a choice, them showing up. Sure, we have some mandatory clients where, counseling is mandatory, whether it's some kind of offenders. But typically in private practice, we are like, it's your free will. We are not forcing anyone to come to therapy. Don't overcomplicate with theoretical jargon. Don't try to go so deep that you get confused yourself. So having some kind of a crystal clear model is preferred. And forgetting to update information as therapy evolves, because we have our own biases. As the client walks in and they're anxious and you've written that, but now they become more comfortable with you. They were only anxious because they were changing jobs. It was a new job, but they're actually comfortable in the skill set they have in the new setting, new environment, but we haven't updated the information. So make those, update your formulation. You were using CBT, but now you think that this person might be better for IFS or EFT model. You can make that change in a very, what should I say, in a very graceful manner. And there is a rationale behind it, right? This candidate might be suited for this kind of modality. Or we've done enough mindfulness. They said they don't find it useful. So we're not going to be using self-compassion work. Perhaps we'll use another technique, another modality, another intervention. So what I want you to remember, your key takeaways: conceptualization is a map. It's not a rigid answer. It can be evolved. So it's not set in stone. It should integrate both challenges and strengths. Sometimes our work is so based on, the old school way of thinking, this is wrong with the client, that we forget what is right with the client. How did they get that strength to come and talk to someone, right? They're choosing to be vulnerable when they're sharing their problems with us. So we are acknowledging that, we are validating their feelings, and it must be theory informed. So case conceptualization based on our theoretical models, but it's client centered, right? If it needs to change, shift, evolve, we are ready to do that. So also review and revise as your therapy progresses, and that will help you stay on top of your notes as well. We try to finish them as soon as our session ends. If you can do that, great. If not, don't be hard on yourself at the end of the day, before you leave the office, before you shut your computer, as well as within 24 hours, 48 hours at the most. Otherwise, they start piling up. And then you will start hating the work you do because you're caught up in paperwork, red tape, and not actually doing the clinical work that you might enjoy more. So if you want to dive a little bit deeper into this, some of the references and further reading I would suggest. Sperry's work is really popular. That's what we studied in our graduate school, but you can also look at the other resources. Handbook of Psychotherapy is very popular by TDL's, Nezu's work, or Sperry's. And if you guys have any questions, concerns, shoot me text, write me an email, um, talk about it in supervision, and I'll be happy to help and support you more. Thank you so much, guys. Thank you for watching this. Share it with friends and folks who can benefit from this, and use it as a baseline, as a guide as you continue your work.